Prohorenko, everyone. We're going to get started on the second session for our track one, which is the track of our conference on the second day that's focused on issues really related to trauma and the major healthcare issues near the front lines of the war in Ukraine. We just finished our first session, which was on tourniquet syndrome, which is a major issue, and it's an issue that's related to the fact that one of the biggest killers of both soldiers and civilians on the front lines is bleeding. If you don't control bleeding, the patients don't survive to make it to the operating room, to be able to make it to the rearward hospitals in order to be saved. So part of that is the use of tourniquets, but another major issue is once those that are saved and that make it to the stabilization points and to the mobile hospitals near the front lines, they oftentimes have lost tremendous amounts of blood or will have to go through procedures where they will lose even more blood. So the issue of resuscitations, the need for transfusion, for damage control resuscitation, this is another huge issue. And we're here to talk today with some topic experts on this. We're going to start. We have online, one of our participants is a retired Colonel, U.S. Colonel Andre Kapp. We will be starting with his presentation, and then we'll continue with our panel, which includes my fellow Med Global colleagues, Dr. Michael Samotowka, Dr. Chandra Hassan from the United States, and with our esteemed colleague from Ukraine, Dr. Gregory Prohorenko, who's from the Lviv Military Hospital. And so we will start with Dr. Kapp. Unfortunately, I have not had an opportunity to meet Dr. Kapp before today's event, but I know him by reputation. I'll let him give a more thorough introduction as he leads us off on this session. So we turn it over to you, Dr. Kapp. Thank you.
Good morning. Thank you, everybody, for inviting me to be here. Thank you for the organizers, and it's a great honor to be part of this event. I guess the first thing I just wanted to clarify with the organizers, I understand we're having a panel discussion here. I also had a presentation prepared, but I was wondering whether we wanted to do that or just lead off with some discussion of the topic without formal slides.
Go ahead and give the presentation. Yes, Dr. Kapp. Sorry if you're able to hear me. We thought your presentation would probably be a great lead off to sort of stimulate the discussion. We do want this to be interactive. We would obviously like to see your interaction with our panelists and our other members of the audience. But if we could lead off with your presentation, we think that would be a great way to begin the discussion.
Okay. So I did email it in. I'm on my phone. And so I would need a second here to try to get my computer on the link to get the slides up, if we want to do that. Do you by any chance have it in Drive, or sorry about that.
With our IT, one second. Dr. Kapp, we're going to look into that. So maybe what we will do is actually start with the panel discussion, and if we're able to queue up your presentation, we'll segue to that shortly. So maybe perhaps we start with you, Dr. Kapp.
Sure.
Just start by giving us a little bit of your background and what your your experiences here, particularly as it relates to the damage control
Sure.
resuscitations here in Ukraine. So we leave the floor to you, sir.
Okay, well, I'm a hematologist, oncologist by training, and I never thought I would get into the world of damage control resuscitation. When I was in training, I actually trained in bone marrow transplantation, and that was my intended work, but the Army had other ideas for me. And back in 2009, they transferred the blood research program from the DC area to San Antonio, Texas, where I currently live. And the idea was that they would move blood research from a focus on infectious disease and blood safety towards more developing products to support trauma and resuscitation, which had been and to some extent still remains kind of a neglected area. And so that began my odyssey in this field. And over the years, um, I guess what I would say is that uh, transfusion medicine really was sort of shaken to its roots by the war, global war on terror, and basically we sort of re-examined a lot of the assumptions made around blood products and how to use them um, during that conflict. Where we are today reflects all of that change, and I was sort of in the middle of all of that. Not to say that um, obviously many people were involved in driving change in this area. But it certainly provided me with an interesting perspective on blood and blood products and resuscitation. I would say an organization besides the U.S. military that's had an outsized role in changing practice has been the Thor Network, Trauma, Hemostasis, and Oxygenation Research. That organization was launched by two very uh, big personalities, Dr. Phil Spinella, who's currently at the University of Pittsburgh, and Dr. Geir Strandenes, who is in Bergen, Norway. When they launched Thor, basically the story of Thor was that Geir was the chief medical officer for the Norwegian Naval Special Forces, and he uh, realized that they didn't have really a good resuscitation plan for combat casualties. And as a member of NATO, they were sending people to Afghanistan. They were also involved in the anti-piracy mission off the coast of Somalia. And he saw a tremendous risk there. And so he wanted to start up a program for blood-based resuscitation of major hemorrhage with a focus on whole blood. And um, nobody was really doing that at the time, except for Phil Spinella, who had published a bit on this. So he reached out to Phil and said, "Would you be on my scientific advisory board?" And next thing you know, they decided to host a meeting. First meeting occurred in 2011. I was actually deployed, so I didn't go to that meeting at that time, but I did go to the next one in 2012, and everyone since then. And uh, saw with in Thor a kind of partner organization that would really help, I think, catalyze change in the U.S. military and in NATO. So, indeed, over the next decade, really, a dozen years, between Thor, the NATO Blood Panel, with which I got involved pretty early and ultimately led, um, and the work in the lab at the ISR, we were able to recruit a large number of like-minded people who were willing to sort of question the orthodoxy of what previously had been um, dictated in the world of transfusion medicine and make some change. So, what are the big changes? I guess you could ask. Well, first of all, a little history I think is in order. So, in The story of transfusion medicine and combat casualty care really begins back in World War One. Um, Essentially, the people have been trying for about 200 years to figure out a way to transfuse blood. I mean, once blood and sort of vascular circulation was understood by William Harvey, it became intuitive for people to say, well, if somebody's bleeding, we should probably put the blood back in there because the body is sort of organized to pump blood around. And so that very basic concept was understood a long, long, long time ago. But actually transfusing blood safely was a challenge. And in fact, the early on, people said, well, maybe we can put some kind of a substitute in there for the body to pump, and maybe that'll sustain life. And people tried cow's milk and all sorts of things that totally did not work out, as you can imagine. And so finally, people settled into the realization that we would have to put human blood back into humans. Tried sheep's blood and God knows what else. Um, and obviously those were problematic. So finally, in World War One, blood was successfully transfused because we had Karl Landsteiner had discovered blood groups, and we sort of understood compatibility. And separately, we understood how to prevent blood from clotting when we collected it with citrate. So those discoveries came together and allowed not only direct blood transfusion, as it was first done in 1916, um, but actual collection, storage of blood, and transfusing it to bleeding patients on the front line, even in the pre-hospital setting. I mean, so this occurred, as early as 1917. And by the end of the war, everybody realized that this was the way to go. And it was much better than all of these so-called blood substitutes people were using at the time. And they tried everything. They tried normal saline, lactated ringers, various colloidal solutions, and all of those were sort of flash in the pan compared to what blood was able to deliver. Unfortunately, at the end of World War One, the that massive uh, collection of experience that people had kind of got, I would say, frittered away because there was no organized attempt to develop real blood systems until much later, right around the period of World War II. Um, Interestingly, in World War II, people understood that blood was going to be useful, but this kind of wishful thinking concept set in again. And the United States said, well, it's going to be really hard to organize a blood program at scale to support combat operations once we decided that we were going to get involved in World War II. And so the thought was we're going to use this new technology called lyophilization, freeze drying, and freeze dry just the plasma component of blood. And that was considered like this is going to be good enough. And we learned the hard way that it's not a complete substitute for the rest of the blood, and that you actually, at some point, will need some red cells and platelets to support patients. And so what ended up happening was we continued using this dried plasma as a pre-hospital bridge or to whole blood or as an extender of whole blood. And that's what really worked out well. That continued through the Korean War. Unfortunately, we still didn't understand blood safety very well. We didn't understand how to isolate viruses and all that kind of thing. And so hepatitis as a disease was not well understood. And we did the lyophilization with huge pools of thousands of donors, and you get one or two infected donors in there, and it contaminates the whole pool. So it gave a lot of people hepatitis. So at some point in the Korean War, people decided, you know what, maybe we shouldn't be using this product, and so that's where uh, we ended up, and we stopped making dried plasma in the Korean War. So, fast forward to Vietnam, and basically in Vietnam, uh, we saw again, this development of um, a wishful thinking kind of concept where we were treating a lot of patients for heat injury with, crystalloids like saline. And
And Colonel Cab,
yes,
not to interrupt, I apologize, but I wanted to let you know we have your whole presentation uploaded and queued up. So if you want to do this off of slides, please feel free to. Um, um,
sure. So I think what I can do is I'll just finish off the historical background because that leads us to why are we talking about dried plasma, which is
Perfect.
the topic here. But yeah, anyway, so we're getting there. And so, anyways, one of the interesting things is that blood loss causes tissue hypoxia and potentially ultimately organ failure. This was recognized in World War II. A Dutch physician developed the precursor of dialysis in 1945. In Vietnam, there was a lot of renal failure I mean, not in Vietnam, in Korea, sorry. And people studied it in combat casualties and realized that one of the problems is that when you lose blood, fluid flows from your tissues back into the bloodstream, all that interstitial fluid. Which is why, actually, when you see a patient first present after major hemorrhage, their hematocrit is lower, which, if you have thought of blood as just sort of pipes with fluid in them, it shouldn't change the composition of the pipe, the fluid in the pipe to to lose pressure, right? But in fact, there is this sort of autohemodilution that occurs by loss of interstitial fluid. So if you put blood back into the patient, you only some of that fluid ends up getting back into the tissues. And so these researchers in the 50s and 60s realized that, probably a little extra fluid for the tissues would be helpful. This idea of resuscitating the interstitium came about. Unfortunately, you know, there was some misinterpretation of this, and the idea was like, well, we just give clear fluid until and see if that's enough, and eventually we can give blood, and that is sort of what got encoded into principles like ATLS for many years, where you sort of do this shock responsiveness test with clear fluid, and if that doesn't work, you give red cells, and then eventually plasma platelets and the rest. What we discovered in Vietnam was, but we didn't really realize it, was that that was not a good idea, and you ended up giving a lot of clear fluid, and we created problems like denying lung, aka ARDS, acute respiratory distress syndrome, and abdominal hypertension with the inability to close the abdomen after a laparotomy due to tissue edema. And that sort of approach persisted along with the development of component therapy through the 70s and 80s. We go to war in the early 2000s with this component-based approach to resuscitation. Once patients reached the hospital, and in the pre-hospital setting was all crystalloid. And people were bleeding massively, and they got a lot of crystalloid, and a lot of people became hemodiluted and coagulopathic and bled more, and it just did not work out well. And so we eventually had this switch to whole blood with a sort of intermediate phase, I would say, of component therapy that sort of looks like whole blood, the so-called massive transfusion packs of 1-to-1-to-1 ratioed platelets, red cells, and plasma. But where that all kind of leads us back to is the beginning of transfusion medicine, which is whole blood. You got to put back in what the patient lost is the bottom line. Um, where plasma comes up, which is what we're going to talk about in this presentation, is uh, the planners for World War II were right in the sense that providing whole blood at scale in the pre-hospital setting, especially, is really hard to do. Obviously, precious resource, but not only that, there are cold chain requirements, and if you don't use the whole blood within a relatively short period of time, you know, 21 days if you collect it in the anticoagulant CPD, or up to 35 days in CPDA, then you waste it. So in order to avoid waste, you have to create these programs where you put the blood in the pre-hospital setting for about a week or two, and then cycle it back to the hospitals for use in a more high volume utilization scenario. That can work exceedingly well if you're very organized and you have good cooperation between your blood center and your trauma services and your EMS services, as we do in San Antonio, Texas, where we sort of pioneered this approach. But in more rural areas, it's harder to do. So there's definitely, um, this tension between the ideal product and its feasibility in all the settings you want to have it in. And so people are looking for an opportunity to put a product in that will be more stable in the pre-hospital setting, allow for greater flexibility, and extend what you can get in resuscitation from whole blood. And here comes dried plasma once again as the obvious solution to that. So with that, I think we can jump into the slides. Um, I'll just pause there for, I've kind of been speaking here for a minute. Anyone have any reaction or discussion before we dive into the slides?
Well, I just have to say that historical perspective was fantastic to lead off and to lead in this. And I also have to say, as one fellow Texan from San Antonio, that's my hometown, it's nice to see you online presenting with us. We've got Dr. Hudson Berry, a fellow. Texas is well represented here today. so,
Very
so,
good.
to that point, does anyone have any questions or comment before Dr. Cap jumps in? Okay, please proceed, Dr. Cap.
Okay, so if we can go to the first slide after the intro here. All right, so just for everybody, for transparency here, these are my disclosures. Since retiring from the Army, I've kind of taken on a career in product development consulting, because that's what the Army had me do, and that's what I'm continuing to do, basically with the same ends of providing more products for trauma and critical care patients to improve their outcomes. So I am on the board of directors and was recently named Chief Scientific Officer of Velico Medical, which makes products, devices that allow blood centers to dry plasma. I'm also a consultant to the Department of Health and Human Services Biological Advanced Research and Development Authority, BARDA, which basically invests in technologies that will provide medical countermeasures to major threats to the civilian population. I support the radiation and nuclear threats branch, and an interest in that area is blood products for a variety of reasons. And so I consult to BARDA and the federal government via Tenel Government Services as a contracting firm. And then I'm also a volunteer clinician at Brooke Army Medical Center, where I practiced for a long time, and on faculty at Uniformed Services University. So everybody knows where I'm coming from. All right, next slide, please. Yeah, I should add that my opinions that I'm going to share today are my own and not the federal government's, Department of Defense, Health and Human Services, or anybody else. All right, so sorry, was there a question?
No, there's not. We had a brief internet lapse, so please proceed.
Oh, yeah, okay. All right, great. So, hemorrhage is the number one cause of death, potentially preventable death on the battlefield. And even in civilian trauma deaths, hemorrhage is really the driver. Um, and in fact, trauma is the number one cause of mortality in patients around the world below the age of 45. So, you know, younger patients who potentially have a lot to offer to society disproportionately suffer death from hemorrhage and trauma. So this is a colossal global public health problem, and I don't need to tell you that this is a major problem in Ukraine, obviously, so it's why we're talking about it. Next slide, please. So, as I mentioned in that sort of historical preamble, it took us the sort of last big wars of the sort of drive the origins of GWAT in the 20th century, but really early 21st century. Kind of reviewing all that history real time on the battlefield, to learn that, yeah, in fact, giving blood instead of clear fluids is good. And in fact, the earlier you give that blood to bleeding patients, the better they do. And, you know, this is sort of self-evident. We all learn in basic life support the first thing you learn is CPR, right? And basic life support in your journey to becoming a healthcare provider. And if the heart stops beating, you got to beat for it immediately, because tissue hypoxia kills sensitive tissues like the heart, the brain, and kidneys. And you don't have a lot of time. And so, if on the other hand the heart's fine, but it has nothing to pump, the net outcome on the tissues is exactly the same. And so, the longer you wait to put blood back into the patient, the faster they die. Now, what Stacy Shackelford from the Joint Trauma System and her colleagues found in looking at all the trauma mortality in Afghanistan was that patients who sort of did the national experiment of being picked up by a helicopter that had blood on it versus being picked up by a helicopter that didn't have blood on it, was early transfusion saves lives. And really, for massively bleeding patients, that means, in the first 30 to 40 minutes, they got to get a transfusion. Now, I would mention to you that this data comes from the era before whole blood was widely adopted, especially for pre-hospital use. So these patients were all resuscitated with a plasma, or red cells and plasma together. But just that caveat out there that, you know, we've sort of done the natural experiment and on a large scale on the battlefield and shown clearly better survival if you resuscitate early with blood products. Next slide. So I touched on this quite a bit in the preamble, so we won't spend a lot of time here, but I will say that Phil Spinella and his colleagues deployed in Iraq did observe that patients who got more plasma in relation to red cells uh, did better. And the graph on the right shows you this. Patients who got sort of a resuscitation that was crystalloid heavy and red cell heavy and not a lot of plasma had super high mortality. And as you added plasma in and substituted that for the crystalloid, mortality came down tremendously. This is the most cited figure in all the medical literature from the global war on terror, and it demonstrates, I think, pretty clearly that you need the plasma as well as the red cells. Now, just people have thought, well, this is because we need all those coagulation factors to clot blood, otherwise people bleed and so forth. And I think that's true to an extent. So people have termed this hemostatic resuscitation. And, it is in the sense that giving people crystalloid in large volumes is anti-hemostatic in that you dilute the blood, and so saline doesn't clot very well. And that is what people were observing, is sort of blood running like Kool-Aid, as they say, with large volume crystalloid resuscitations, and you got away from that. But I would say that giving plasma back is actually a little bit more complicated, because it's not just that you're sort of giving coagulation factor, but it's that you're really restoring homeostasis to the body. Um, we've found that actually crystalloid is sort of irritating to the vascular endothelium, the lining of the blood vessels, whereas plasma acts in a way that helps restore normal balance to that tissue. In particular, restoring the lining, sort of complex carbohydrate lining of the endothelium called the glycocalyx. So that gets sort of washed away by saline and other crystalloids, and the plasma actually helps it rebuild. So it's actually more complicated. It's really bringing the body back into balance by giving plasma along with the red cells that's important here. So next slide. So, in the scientific community, we presented all this data from Iraq and Afghanistan, observational data, right? These patients weren't randomized except in a sort of natural experiment way of, being picked up by a helicopter that does or does not have blood. But it's not the same thing as a randomized controlled trial. So the Department of Defense funded a number of studies in the area of blood-based resuscitation, and this one in particular addressed the question of, can plasma really act as this bridge to full, we'll call it whole blood resuscitation or full component resuscitation? Is this concept truly valid? And so this was the Pamper study published in New England Journal of Medicine. This was led by Jason Sperry and colleagues at the University of Pittsburgh. This was a large multi-center study. And what they found was that giving 2 units of plasma to patients being aeromedically evacuated for major trauma and hemorrhage um, resulted in a lower mortality than patients getting the standard of care. What was the standard of care? It was mostly crystalloid, but they could also receive a unit or two of red cells. Interestingly, the patients who got the plasma first and then got red cells did even better because you're getting back towards whole blood, as you can imagine. But nevertheless, this did validate the concept that giving 2 units of plasma as a bridge to full resuscitation while the patient's en route to the hospital is much better than giving crystalloid or crystalloid plus red cells. How much better? Well, the reduction in mortality was 30%. That's huge, right? So this really provides us some excellent, level one evidence from a randomized trial that this concept of plasma as a bridge to whole blood is, or to full resuscitation, we'll say, is a valid idea. Next slide. Now, you might ask the question, and people have, uh, is this a cost-effective approach, or is this going to break the bank? Can we really afford to devote these resources? So the authors performed a cost-effectiveness study that I think is really compelling. They used the World Health Organization endorsed threshold of what constitutes cost effectiveness of $100,000 per quality adjusted life year saved. And they analyzed the cost of the whole pre-hospital resuscitation program. And what they found was the average cost per patient treated with plasma up front was about $274,000 more than the standard of care randomized patients. And where did that cost differential come from? Well, the vast majority of those costs were ICU and rehabilitation costs in patients who would otherwise have died. So it turns out that the way the study was done, even with that average cost increase per patient, the quality adjusted life year cost was about $50,000, a little bit under that. So well within the WHO threshold levels. The authors, and you see that in the top graph there, modeled against various scenarios. Now in the bottom graph, the big sort of purple, orange square with a little blue, slash in the corner, it represents modeling of patient volume and units transfused. So you might, think, well, if I have an evacuation platform that doesn't see very many patients and doesn't transfuse much plasma, I'm wasting all this plasma. It's going to be expensive, whatever. And if you do all this modeling, what you find is that plasma is still a cost-effective solution in almost every case, unless you have like almost no patients evacuated over a year, and you assume pretty high costs for the plasma, and that's that little bit in the blue. So the bottom line is that this is a cost-effective intervention across pretty much most scenarios you could conceivably encounter, at least in civilian practice. So we have both efficacy, well, safety, efficacy, and cost effectiveness for this intervention, which is pretty exciting. You don't often find that trifecta in clinical medicine. So that's very encouraging. Next slide. So what about the situation in Ukraine? Does Ukraine need a dried plasma program, or we'll just say a plasma program for the pre-hospital setting, or a whole blood program even? And I think, I'm not going to tell this audience that, there's a lot of bleeding and a lot of trauma in Ukraine right now. Unfortunately, we know this. But the graph on the left is a really interesting one, published in The Economist, uh, comparing the ratio of wounded to dead across conflicts through history where we have any relevant data. And I just want to point out that, the data that supports all of this work from the United States is really coming out of Afghanistan and whatnot. And you see that the little dot there that where I've drawn the arrows, you know, Afghanistan had a wounded to kill ratio of about 10 to 1. The Economist here is estimating a wounded to killed ratio of 3 to 1 for Russian forces in Ukraine. We know that thankfully that's lower for Ukrainian forces, but the point here is that the lethality of this conflict is significantly higher than anything really since World War II. I mean, it's World War II comparable. And as you may recall from the sort of preamble in the early slides, this is where we figured out by dint of extremely high volume experience that having pre-hospital blood-based resuscitation was a great idea. And that was based on plasma, ultimately building to whole blood. I would argue that, obviously, if you can give whole blood in the pre-hospital setting, you should do that. But if you can't do that, we have randomized trial data that says it's never been compared head to head with whole blood, but certainly it's been compared to plasma crystalloid versus red cells, and it's clearly better than that. So really, you're back into a scenario kind of like World War II, where we evolved to this, plasma as a bridge to whole blood model. Just for the rural setting, and Ukraine is a large country with agricultural areas and very rural parts of the country. So in peacetime, you might think about comparing to some other data that's come out of countries that have a lot of agricultural space or open space. So here I've got some data from Australia, but there's data very similar to that in the United States, and it shows basically that the farther away you live from a trauma center, the longer your evacuation times are, and the longer you're bleeding and away from surgical care, the bigger problem you're going to have. So again, I think even in peacetime, there's a case to be made for pre-hospital resuscitation with whatever is feasible, and that could be plasma in Ukraine. So I think what we're talking about clearly applies to Ukraine. Next slide, please. Sorry, I apologize. My voice is a little bit congested here, but so okay. So if we take it, if we stipulate that the data are good enough and the historical experience is robust enough that we want some plasma in the pre-hospital setting, it's a good idea. And by the way, the U.S. federal government has invested massively to provide this not only for the U.S. military, but really for the entire civilian population. BARDA has invested significantly in the development of plasma drying capacity through Velico, in part because they want to make sure that all the major blood centers in the United States are equipped to make dried plasma so that it can be available in the event of national emergencies, but even on a day-to-day basis. So what I'm telling you here is not just my own perspective, but the U.S. is sort of walking the walk as well as talking the talk, and investing massively in production capacity for dried plasma. But anyway, so there are really two ways to get to dried plasma. One is you can have a facility make it for you, um, or you can make it yourself. Those are sort of your two options. Right now, if you wanted to acquire plasma from another supplier, what are your options? So the German Red Cross makes a product called Lyoplaz, which is a single donor freeze-dried lyophilized plasma, kind of similar to the concept of um, a World War II era product. The French military actually makes something a lot closer to what the U.S. fielded in World War II, which is pooled donor plasma to make a universal product. So it's not blood group specific. It is pathogen inactivated using the Cirrus Intercept amotosalen and UV light technology. Um, and it's made by the French Military Blood Institute, the CTSA. And then there's an organization, National Bioproducts Institute in South Africa, that makes bioplasma, FDP, pooled donors, pathogen reduced with a solvent detergent process. And those are have been the major products on the market. Just recently, the biologics company called Octapharma that is well known for making plasma derivatives like factor VIII and factor IX and prothrombin complex concentrate and fibrinogen, et cetera, has gotten CE marked for a pooled solvent detergent pathogen reduced plasma called Octaplaz LG Lyo. All of the products you see are pictured here on the right. They come in glass bottles, and they provide, essentially a clinically, we think, similar product. The There are some challenges with these products in the pre-hospital setting. Obviously, large glass bottles are not ideal. They can break. They're bulky. They take up space. They're heavy. But it's kind of what's available right now. Great. So these would be the products that you could go out there and try to bring into Ukraine. My understanding is that some of these have actually been fielded in Ukraine, including the Lyoplaz and possibly the Octapharma product as well. Just note that the French military product is, used by the U.S. military by our Special Operations Command. It's a great product. It is, however, available in very limited quantities. Same thing with the South African product. And so availability of these products is pretty challenging. Next slide. So, what about making it yourself? So BARDA has invested about $150 million to date over the last dozen years in Velico's technology of developing a relatively inexpensive system that could be located at blood centers around the world to make spray-dried plasma. So the difference in freeze-drying and spray-drying, in freeze-drying, you take a frozen block of plasma and you subject it to a vacuum and then gently warm it, and the ice sublimates out and is removed through that vacuum out of the block of ice, leaving the proteins behind. In spray drying, you pump the plasma through an atomizer that makes a little spray of plasma, and you hit it with a warm gas, or just actually clean, dry air, and the water evaporates out of the little droplets, and the plasma falls to the bottom of a collection chamber. and you get dried plasma. So both processes are, extensively used in pharmaceutical manufacturing, but adapting them for drying plasma has been a challenge historically. And so spray drying, um, getting the process down to something simple that could be used in any blood center that doesn't require a clean room, and that can be operated by anybody, required a lot of engineering. And so that's what you see here. So you take a standard plasma unit, you sterilely dock it to a pretreatment solution, and then sterilely dock the resulting product to a plasma drying chamber, which is a plastic disposable that goes inside the spray dryer. You press the big red button, you come back 30 minutes later, you take the dried plasma out, you put it in the sealer, which is next to you there, and the sealer shakes the plasma down into the collection chamber, seals the bag, cuts it, and you're left with the product that can then be spiked, reconstituted, and infused. So, next slide. So what the spray drying process leaves you with is then this spray dried product you see on the left. It's packaged with a transfer line, so you can spike the sterile water for injection, connect it to the dried plasma, and reconstitute it into the plasma you started with. You took the water out, you put the water back in. That process takes just under 3 minutes. We'll say around 3 minutes on average, and it's ready for use immediately, which is pretty nice. Next slide. So dried plasma in general eliminates some of the cold chain requirements, particularly at the end of sort of the terminal use, right? The dried plasma is stable at room temperature, so you don't need a freezer in your ambulance. You don't need a refrigerator. You're ready to go. You don't have to have that recycling program to send the product back to the hospital before it expires with short shelf life products that are like liquid plasma or thawed plasma or even whole blood. And so it provides availability at the point of injury that you would not otherwise have. So it really kind of ticks all the boxes. Next slide. While that is true for all dried plasmas, the difference between those and the spray drying process is that the spray drying, you can leverage all of the blood center based production infrastructure and capabilities. Um, and distribute manufacturing across your entire blood system instead of just having it all in one place. Um, Interestingly, in the United States, frozen plasma has a shelf life of a year, but dehydrated plasma is probably, products aren't marketed yet. We're still, working through a regulatory process, but our testing indicates that shelf life could be easily 2 years stored refrigerated, or 6 months to a year stored at room temperature. So, you sort of extend the shelf life of the product if you store it refrigerated and dried compared to frozen, which is nice. And then finally, the product is easy to make, store, manage, and use, and that is helpful. So, next slide. The process for making dried plasma with the spray dryer is, as I described earlier, really pretty simple. All of the material, other than the sprayer and the dryer, are available in any blood center around the world. The whole processing time is very short. It takes about 5 minutes to prep the unit, 2 minutes to load it and get it ready, hit the button. Spray drying, as I said, just over half an hour, around 37 minutes. The sealer takes 6 minutes. Takes a minute to package it all up in an overwrap and get it ready for delivery to the ambulance service. It's a really rapid, simple process. No particular training required, other than sort of on-the-job training. Next slide. So one operator working an 8-hour shift, 5 days a week with one dryer and one sealer can make 12 units a day. So, 60 units a week, which turns into 3,000 units a year, which is about what the French military makes in their lyophilization system, which, by the way, to build a new one of those would be, probably about $100 million. So next slide. same operator can actually operate 4 dryers at a time. So 8-hour shift, 5 days a week with a sealer. You're making on the order of 12,000 units a year, which is huge. That's probably, comparable to what anybody can make. And these are relatively modest investments to do this. So the production capacity is enormous. By the way, this is one person, 5 days a week. This is not surge capacity. You could easily have 2 shifts running, and you could run it, 6 or 7 days a week. And so you could with the system here, you could make perhaps up to 30,000 units a year, which is really pretty much the capacity of any manufacturer today. So really, this is a revolutionary breakthrough in making this product, dried plasma, available everywhere. And really, the goal is that nobody should ever be resuscitated for bleeding using saline again after this uh, product becomes available, because it'll be cost effective and cheap enough to do that. Next slide. So again, Velico manufactures the systems and the consumables that go to the blood centers. Blood centers make the product and distribute it wherever it needs to go. That's the system idea. We are testing the product in a clinical trial, which is just about complete. We anticipate regulatory filings with the FDA in uh, early 2025, and then also for CE marking shortly to follow. So obviously, we think that this is making good progress, but could be, that it takes a bit longer to actually get it to market, depending on what the regulators have for us. But that's kind of where things stand right now. Next slide. So the one thing I want to leave you with here is that this process is so robust and relatively simple that it can be put in a container, standard shipping container, as you see here. Um, This has been called the Velipod. This is a very small version of it, but you can put multiple uh, containers together to make a large mobile laboratory. Why would we do this? Well, some feedback we got is that a lot of blood centers are already constrained in space, and retrofitting space, sort of a zero-sum game. First of all, if I put this in there, then I got to take something else out, and I can't, because everything's critical to my operation. So that was one challenge we faced. By the way, the devices are about the size of a refrigerator. The dryers are about the size of a refrigerator, so it's not huge. The clean dry air compressor is about half the size of a standard shipping container, so you need to find a space for that. So, with that feedback, we said, well, if we containerize the whole thing, then you could put it in your parking lot if you want to do that, and you don't want to refit your building. In the specific instance of Ukraine and in other countries, unfortunately, facing war, we know that healthcare facilities have been targeted. The advantage of a velopod like this is that you can put it on the back of a truck and move it around and not have a sitting target in one space, in one spot, to be destroyed by enemy missiles, etc. So there's a security advantage and survivability advantage as well. And by the way, this can be paired with, customized mobile containerized blood collection and processing laboratories to do the rest of the blood collection as well. So you can kind of have a whole mobile blood center if that is desired. And there's been a lot of interest by militaries around the world in this concept. So this is really where I'm going to leave you with the future of blood and resuscitation for major hemorrhage. You kind of got in the perspective over history. Um, we need something in the pre-hospital setting desperately. Whole blood is perfect. If you can't do whole blood, then do plasma. Dried plasma offers a lot of advantages over pretty much everything else. It is now going to be more available and more feasible. Um, Hopefully in the very near future, once we clear regulatory hurdles. And it can even be a survivable piece of infrastructure in a conflict zone. So thanks very much for allowing me to share that with you, and I'm happy to jump back into discussions.
Thank you. Thank you. Historically, that was an incredible recap, and that discussion of the dried plasma opportunities, Dr. Cap, was phenomenal. Before we jump into the discussion, I just wanted to make sure everyone in the panel or in the audience, and this includes our online audience, if you have any questions before we move on. And Dr. Hudson Berry will give you the microphone first.
Oh, that's pretty impressive work, and I think it's a major advance. Can you tell us how much the expendables cost, and and with the Velopod, it has its own generator, I assume, and is it gas, diesel? How much fuel is provided with that, or is that an external resource that you have to obtain?
So, we're talking about products that are not yet on the market and still require regulatory approval. So this is all, in one sense, what I'll talk about in terms of cost is a little bit notional, but based on our cost of production and what the federal government has invested in making a large volume production line here in the United States. So we will have two production lines, and we have one currently that can make around 40,000 plasma drying chambers a year, and the other one's going to be scaled to something minimum of 250,000 with surge capacity of perhaps double that. So really pretty substantial production capacity. And so, you know, like everything else, there are economies of scale, and so the more you produce, the lower your costs. We sort of model at a low production rate that the consumables might cost on the order of $450 to $500 a unit, but that could drop to the 300 to 350 range at full production. So this would put a unit of dried plasma, at least by U.S. pricing, in the ballpark of a little more than a unit of red cells, a little less than a unit of platelets, but with substantially lower waste due to shelf stability and so forth. And so again, providing that cost-effective, by the way, that cost-effective pre-hospital resuscitation. I just mentioned that in that cost-effectiveness study that the Pamper trialists performed, the cost of the plasma program, even with a huge amount of waste, was only 7% of the total cost. And so, if you look at the cost of lives saved, the plasma component of it is trivial. And they were using thawed plasma, wasting most of it. For a dried plasma product, cost is higher, the waste is lower. You're still going to end up in that sweet spot of much less than $100,000 per quality of a year life saved. And it's still going to be a highly cost-effective intervention. As far as the Velopod goes, so this is a modular scalar system. The electrical system is designed to be compatible with NATO generators. You need a 400-volt service for um, uh, the compressed air system, which would be in its own separate connex. And the rest functions on 220 volt. So basically, standard generators available in the field would be sort of plug and play with the system, but they would be supplied separately. Um, And the fuel is whatever, diesel, JP8, you name it, depending on what your system burns. Or you can connect it to main power lines. I mean, it's agnostic as to power source. Um, did I answer your question, sir?
Thank you, Dr. Kapp. Really interesting talk. My name's Ian Nesbitt. I'm working with the David Knott Foundation in Ukraine at the moment. The reconstituted plasma is going to be a smaller volume than the current plasma that's used. So presumably it will alter the ratio and total volume replacement in early protocols. So have you had any thoughts about how you might suggest changing ratios or changing volumes or adding an additional volume resuscitation element to the future resuscitation?
That you're touching on an area that's complicated in the world of blood products, right? Because blood products, there's no, everything is sort of within a volume range. It depends on, when you do a whole blood collection, you're sort of shooting for a collection range. It's never quite exactly the same volume. Separations are, barely similar, but there's always a range. But you're right. The reason, so the product we'll have is to be reconstituted with 200 milliliters of sterile water for injection, and the reason for that is because we based it on historical precedent. So like the German Lyoplast product is similar, right? It's a 200 ml thing. The French product, all of that is based on the World War II product. Now, what's funny is that anecdotally in World War II, the medics came back to manufacturers and said, 200 mils of plasma is not enough in a patient who's bled a lot. We frequently give 2 or 3 of these bottles. And could you make us a 600 ml bottle of dried plasma? And, there were there were 400 ml test products produced and 600 ml and so forth. And so really, this is a quandary we've been facing for almost a century here. But you have to start somewhere with a dose, right? And so because of all that historical precedence, we said, fine, it's going to be 200 ml dose. That is slightly less than a typical unit of FFP that would be recovered from whole blood. What are you going to do about that? I think you're going to, use it the same way that World War II medics did, is you're going to give 2 units and say, maybe we need to give 3 units to this particular patient, but it's going to be in that range of 2 to 3 units. What else would you give? I mean, if you add crystalloid to that, you're sort of diluting the effect. You could give, I suppose, something like 25% albumin would be a reasonable choice. But one of the problems with albumin is that its volume expansion capability depends on there being adequate amounts of interstitial fluid. And if you've bled down a lot and already lost a lot of that fluid, you're not going to get the same bang for your buck, as you otherwise might. So it's a little bit, hard to guess in any particular patient what their overall volume status is. It's very hard to assess that in the field. It's going to be low, but sort of how long have they been bleeding and how much of that interstitial fluid have they lost? So I think at the end of the day, you're just going to get more plasma if you encounter a patient who needs more plasma. So the 2 times 200 ml, 400 ml plasma is going to be, you know, maybe 80% of what you would have given in the Pamper trial. Maybe a little bit, somewhere in that range. And so maybe you need a little bit more. That is quite possible. Ultimately, I'm sure people will do trials, and in the trauma setting and with dried plasma, and we'll see. Now, you're going to potentially tell me, well, they've done that. The refill study in the UK studied Lioplas actually with red cells, and that was a negative study that did not demonstrate a survival benefit. But there are some real issues with that study that I think bear discussion. So first of all, the overall mortality in that study was 40%, which is like 40% mortality in the study. That's colossal. If you look at trauma studies across the world, typically mortality rates are anywhere between 9 and up to 30% for prolonged, air medical evacuation cases, as was seen in Pamper. But even so, the overall mortality in Pamper was more like 20%. And so like a 40% mortality rate makes you say, what was going on in that study? And one of the things that you find is that it was ground-based ambulances arriving to patients and giving the test intervention, saline versus blood products, an hour after injury. So we talk about the golden hour, and we talk about that pre-hospital data from Afghanistan showing, you got to give blood products as soon as possible, like within 30 minutes or so. You've clearly missed the window of being able to affect major reductions in mortality, which speaks to the need for very far forward availability of the blood products if you want to save lives. And I recognize that in Ukraine, evacuation times have been, anywhere from an hour to 12 hours. Somebody who's got a massive hemorrhage, whose leg's been blown off, and they've got a few fragment wounds in the chest, and is massively exsanguinating, does not have 12 hours. That patient's going to die, unfortunately. We were able to save a few of those in Afghanistan due to air superiority and air medical evacuation. But, if that's not feasible, it's not feasible. But you've got other patients who are not quite so far in extremis, who nevertheless are going to be quite hypotensive for a long time after hemorrhage control is achieved and need some resuscitation. And this is where, having some dry plasma forward is going to be really helpful for them. And then, you're going to have to dose it to effect, is what I would say. I sort of a long answer to your question, but I want to give you some perspective about how we came up with that dose. Does that answer your question?
Thank you. Thank you so much, Dr. Kapp, and thank you to everybody for your questions. Any other questions before we sort of move on to a more panel discussion format? Okay. Please, Michael, go ahead.
Can I just ask a quick question here? First of all, thank you very much for an excellent presentation. I regularly go to trauma conferences every year, and we're always hearing about dry plasma and that it's coming, and everybody always asks, when is it finally going to be here? So two questions quickly. One is, realistically, when can we expect this here in Ukraine to help the Ukrainian soldiers? And number two, you may have touched on it and I missed it, but what is the risk of transmission of hepatitis and HIV with this product?
So, yeah, I share your frustration with, plasma is just around the corner and it's never there. The story of tried plasma development in the United States has had a few bumps in the road since we abandoned it at the end of the Korean War. And some of those have been due to problems in our corporate partners from the federal government standpoint, wearing that hat as I did, and I still do as a consultant. Some of it, really that's been the major problem is that I can't say, oh, the FDA has thrown up impossible barriers. They haven't. This is just problems with product development that one might see in any product. But I think that so when is it going to be available? There's another company I didn't mention, Teleflex, which is making a single single donor lyophilized product in the United States. They have completed a phase 1 trial, have submitted to the FDA, and they are working with FDA on various challenges that they face in their process. I can't give you an estimate on when that product will be available. I know that that's been one of the products that's been sort of like just around the corner, but DoD is managing that project, and I just have no idea. I think Velico, what I can tell you is that we're going to have a regulatory filing in first quarter of 25, and it sort of depends what the regulators say. I mean, best case scenario, the product could get some sort of approval and be available within, before the end of calendar year 25 or early 26. But I mean, that's speculative, so I wouldn't really, that's like everything goes well. Now, as far as Ukraine is concerned, as I mentioned, Lyoplaz has been used in Ukraine. I think Octapharma's product as well. You go out, buy some right now and use it in Ukraine. It's going to cost you. Now, could you have a Velico system in Ukraine? Well, it depends on Ukrainian regulatory authorities. I mean, Ukraine's not bound by the FDA or the European Medicines Agency. They could do whatever they want. And if they wanted to bring the system into Ukraine, we would be happy to supply that. So that's up to Ukraine as to when the product is available there. We've gotten a lot of interest. I'll tell you that we've actually delivered a system to the United Kingdom. They have one installed at NHSBT in Cambridge. Their plan is to perform their own clinical trial for their regulators and then produce the product, at least in the first instance in Cambridge, for distribution to their armed forces and ultimately to pre-hospital civilian providers. We have a system that's also going to go into the Netherlands for evaluation by the Dutch military and by Sanquin, their big blood provider, and potentially scale up from there as well. And we've been talking to a lot of other international partners, Australia, France. We're launching a collaboration with the French military. Actually, I'm here in Paris, calling you from Paris, and we're launching that collaboration this week to see if the system will be appropriate for their needs as well. So, in the United States, the system will be available when the FDA says it's available. Outside of the United States, it's up to local regulators to, make that call.
The infection issue, Dr. Gab?
Oh, yeah, the infection issue. I forgot. Sorry. Yeah, so the Velico system is agnostic to the plasma that goes into it. So you can put a pathogen and activated plasma in there if you like, and you can dry that, or you can dry just a fully tested plasma. In the United States, we consider the products that come out of blood banks to be safe, that are, have been tested for hepatitis, HIV, West Nile virus, syphilis, babesia, what's the rest of the list off the top of my head here? Anyway, it's fully tested product, so it's safe. But if you want, you can dry something that's had additional treatment, such as the solvent detergent plasmas and the amotosalen and UV inactivated plasmas as well. The residual risk associated with blood products in major developed countries, like our NATO partners and the US, is extremely low. Nothing like the product that was available prior to testing in World War II in Korea. So I think the infectious disease risk, we're always worried about it with blood products. Zika came out, Ebola, what about COVID? Was that going to be transmitted by blood transfusion? Turns out no. But, the world of transfusion medicine is always concerned about emerging infectious diseases. So I will say that there's always the future potential risk associated with those problems. And God knows I've lived through all of those, including the Zika testing period. But that said, the sort of classic bloodborne infections, I think, have been dealt with pretty well by testing. It's not required to use pathogen activation in the United States or, for that matter, anywhere else. But many people, in different parts of the world have adopted that. That's fine if you want that. Not required.
Thank you. Thank you, Dr. Cap. One more from Dr. Chandra Hassan.
Aloha. It's been an excellent presentation and very educational to us. I hope it's available today. With the hemorrhage being the number one killer in a pre-hospital setting, and with the mortality rate in Ukraine being as high as the World War II, it's really mind-boggling statistics there. In United States, I'm from Chicago, by the way, and Cook County Hospital was one of the first hospitals to have a blood bank established in 1937, so I'm proud of that. So in United States, about 20% of the blood donors go through this closed RBC apheretic system where donors with a high hematocrit can donate up to 2 units of RBCs, where the plasma and other cells are separated and reinfused into the donor during the same phlebotomy. What's your take on that in the reality of Ukraine? Would that help them more with reducing the death rate from hemorrhage because of the availability of more blood products?
Instituting double red cell apheresis in Ukraine. I mean, that's a great idea, sure. I guess I wasn't aware that that wasn't available in Ukraine, but yeah, I mean, I think donor management is obviously a huge problem we have around the world, actually recruiting new donors, maintaining donors, and maximizing the efficiency of collection from particular individuals, and sort of an element of that, I guess, individualized, personalized medicine sort of approach on the donation side is exactly what you said. Find high hematocrit people and do double red cell collections on them. Yeah, I mean, I think that's an important addition to the armamentarium. As far as plasma is concerned, you can certainly collect whole blood and recover plasma from it through standard centrifugation and expression of the plasma into a separate collection bag. You can also collect by apheresis. Companies like Octapharma and others who make plasma derivatives, Grifols, Takeda, et cetera, all have dedicated plasma donation centers, and people can give plasma twice a week by apheresis, at least in the United States. That varies by regulatory regime around the world. Not everybody allows that, but anyway, U.S. provides by far the bulk of the single greatest source, put it that way, of plasma for further manufacturing, because of this approach to apheresis collections. Just a word on that, I would note that the manufacturers who have these dedicated plasma centers collecting by apheresis are using paid donors in the United States, which have historically been a slightly higher risk population from a transfusion transmissible disease perspective. The way the manufacturers deal with that is, I mean, they do extensive testing on these people, and then in addition, they subject the product to the solvent detergent pathogen reduction technology that I mentioned earlier. So that's the risk mitigation step in plasma for further manufacturing. And the Octapharma dried plasma is made from that plasma, collected by those centers in the United States and then treated. If you're gonna, so I mean, there's a little bit of increased risk there if you're using a large paid donor population, but you don't have to do that. You can take standard donors, volunteer donors and collect them by apheresis up to twice a week and make a lot of dry plasma from it if you like. That is certainly another option in addition to the double red cell apheresis and certainly platelet apheresis that expands product availability.
Well, thank you, Dr. Cap. I want to make a bit of a pivot at this point, and I'm going to first go to Dr. Prohorenko, but what I would like, we have about a half hour left for this session before we break for lunch. I'd like for Dr. Prohorenko to give us the sort of larger scale overview. I think between Michael and Dr. Hassan, who come in as American surgeons, and then with other members of our team like myself, we've probably visited well over 100 hospitals around Ukraine, both from the rear and to the front, and we've all seen the resource heterogeneity and the resource austerity, particularly as you get closer to the front lines. So, Dr. Prohorenko, if you could sort of start us with sort of an overview from your perspective. We know that blood loss is the major pre-hospital setting cause of preventable loss of life. We know that this is a terrible war that has terrible casualties, and I mean, we probably don't want to discuss actually the numbers of units, but it's probably enormous numbers of units of blood that are needed. So if you could sort of just set the stage, and then Michael and Chandra in the last portion of the talk, if the two of you could sort of weigh in as American surgeons, what your perspectives are to that. So Dr. Prohorenko.
First, I would like to say thanks to Dr. Kopp for this presentation. I approached the issues of transfusion, the collection of blood as the user, but now I have also some theoretical understanding. Thank you for giving us the scientific overview. So, talking about the blood service in Ukraine, in the Ukrainian military, first and foremost, there's a dedicated unit. There is a dedicated silo called the blood service, and it has its guidelines and regulations, and it's subordinated directly to the Medical Force Command. And we in the structure have units that are responsible for blood collection, processing, storage, and transportation. It's impossible to overestimate the importance of donation. This is a program supported by the Ukrainian government. Many volunteer donors come to give blood. Talking about the outstanding issues now, yeah, definitely. The quantity of blood we need is significant. So, taking care of this is a challenge for our service. We understand that all the chain of collection and storage near the front line is a huge challenge. So we have to do it at a distance from the front line. So then the storage and transportation become highly relevant, and also the distribution and proper usage and management, because it's expensive to do all that. And the most effective way to use all the resources which we have is extremely important. Currently, we do not have the possibility to produce the lyophilized plasma, but we have the experience of its application in the military through humanitarian missions and through the support of our volunteers. We can and we are using lyophilized plasma used in Germany and France, produced in Germany and France. We understand that crystalloids cannot even be compared to blood products and plasma in particular. And the sooner it happens, the better. So starting from the stabilization points, lyophilized plasma is available there. Also, we have a stock of FFP and the RBC. With the platelets, it's difficult because it is quite expensive to produce and it is stored only for a short period, and transporting platelets is difficult. The blood service is very determined in terms of regulations. There are very strict frameworks. Before the full-scale invasion, we couldn't even talk about whole blood transfusion. But as the war began at the legislative level, it was allowed to apply whole blood or even direct transfusion. And all the service members, they have been tested for main infections. They all have blood types and rhesus factors, and the medics who provide care, they have the information about the possible origins of whole blood, where they can get whole blood when needed. And there were quite a few cases when the doctors who provide care to the wounded in hospitals in parallel were also acting as donors to the same patients. Blood loss is a huge problem, especially massive blood loss on the battlefield. We understand, of course, that stopping the blood loss and then restoring the blood flow is the key factor here. So, alongside the efforts to save life, we understand that there are problems linked to hemotransfusion and massive blood transfusion, and there might be subsequent problems, and these patients might need additional care. Here I'm talking about, for example, acute renal failure that might develop in different conditions, and it would require a solution. So it happened that besides the blood service, which is responsible for the collection and transportation of the components, there are also trained people, the anesthetist. By the way, today is the anesthetist day, World Anesthetist Day, so I congratulate whoever is an anesthetist. Blood transfusions is always analyzed and discussed with the colleagues, and hemotransfusion is an operative intervention, and of course indications and contraindications have to be established, and it has to be put in paperwork. It's considered a surgical operation, and of course there is a whole aspect of liability. So lyophilized plasma is easier regulated. We have already the prepared product that can be transfused by an untrained person. So we are now assessing the efficiency of the so-called universal blood, the O- blood, whether it can be transfused at the step points, whether combat medics are allowed to do that. But so far it's still a matter of discussion. There's no decision we understand that there are both positive effects from this, but also complications can happen. It's not so easy. So the problems on donations and blood transfusion and product transfusion, this is a huge work that is done by our colleagues. And if you talk about the collection, then yeah, the donors in the army, that can be service members that are engaged to blood donation. But now we see, unfortunately, that the need for blood and blood products is not going down. And considering the usefulness of this, we need to find the ways to overcome these challenges. So any assistance that is provided is definitely very, very important and useful. Well, briefly, that is it.
Thank you. That was an incredible overview. I'm going to go next to Mike and then Chandra. I would like you to close us out, and particularly focusing in on the damage control resuscitation topic. But Mike, given what we've discussed and what Dr. Prohorenko has just given as an overview, you as an American surgeon have seen it in action from the front to the rearward hospitals. And if you could just give your perspective, being an American physician and knowing what the very resource-rich environment that we tend to have, and your perspectives, having seen all of this firsthand in Ukraine.
Yeah, thank you very much. So I'm very fortunate to work in a busy trauma center, inner city, and I have a very supportive blood bank director who pushed very hard at our facility to have 4 units of whole blood available at all times in a freezer in the emergency room in the trauma bay, ready for immediate use and resuscitation as patients come in. So, it's an incredible gift to have, and it's one that clearly saves lives. So I consider myself quite fortunate to have that. But like every other place, there is a limit to how much blood you have, and even we have a limit in terms of blood and blood products. I think as I've gone around and seen the different facilities in Ukraine, and I can see what we have in the States, I think there's enormous variability. It's my perception that there's enormous variability in what is available across the different facilities in Ukraine. And I think this is a golden opportunity for us to work together collaboratively with our colleagues in Ukraine and the different specialists that we have in blood and blood banking to raise the standards so that all of the facilities in Ukraine, small and large, have a standard to meet, have a certain amount of resources available. I would love to see freeze-dried plasma here sooner before the FDA presents it or allows it to be used in the United States, because clearly it will save lives here. And I think that that's something that we could and should certainly advocate for, because I think it would be a game changer, so to speak, in the care of the patients here in Ukraine. But what I've seen to your question, Doug, is that there's just an enormous variability from one facility to another of what's available. And also the perception that I have is that those who work in the blood bank are not necessarily communicating as well with the providers who use the blood and blood products. So, for example, one discussion that one of my colleagues had with a blood bank provider was that, well, we don't really focus our attention on platelets because nobody ever asks for platelets. And then you turn around and talk to the trauma surgeons who take care of these patients, and they'll say, well, we never ask for platelets because they're never available. And that's a disconnect in the system. And I would urge the Ministry of Health to sit down and have difficult discussions with the various chiefs of the blood banks at the hospitals and incorporate the anesthesiologists who manage the critical care here and the trauma surgeons and have a heart-to-heart talk about what do we really need, what will help to save the patient's lives, and how is it best to provide that material in a timely manner for the patients.
Thank you, Michael. And we'll finish.
Yeah.
We have about 15 minutes before we break for lunch. And Chandra, you in particular, you're from a busy practice in Chicago. You have exhaustive experience. You've operated in Ukraine, and you've operated in other very resource-austere environments like Gaza recently. So your perspective would really be valuable, and also your expertise specifically more on damage control resuscitation to sort of close us out today.
Yeah, thank you. What we can do in the reality of Ukraine now is to maximize the use of the development of trauma resuscitation, even in our own lifetime. It used to be a universal, any patient comes in, 2 wide-bore cannulas, give them 2 liters of crystalloids. That happened even when I was a resident. It has become more individualized now within the one generation. Because we have better understanding of hemostasis, we have better understanding of permissive hypotension. So when this patient comes with massive blood loss, hypoperfusion, anaerobic metabolism, all those things we know. So the take-home point I want to drive here is even when the pH drops to 7.1, that significantly reduces the formation of fibrin. Also, the reduction of activity of factors 7A by 90%, and factors like 10A and 5A by 70% just by acidosis. And if you look at the hypothermia, for every 1 degree decrease in your body temperature, internal temperature, that reduces the activity of blood coagulation factor by 10%. That's why this triad of acidosis, hypothermia and coagulopathy, that we can focus on in our resuscitation in the front lines, and definitely that would save more lives.
Thank you, Chandra. Again, we have another 10 minutes or so. We started a little late, or we don't want to delay lunch. We want to open it up to our audience, both here in the room, but also online for any questions. And just while we're at it, I want to say thank you to the David Knott Foundation for showing up and participating. Your participation has been invaluable, and it's a representation of all the various partnerships that we have going on here in Ukraine that have really been how we've been able to amplify our impact. So we've got people in the room or who come from the UK, from the United States. We've got friends from Germany, and I'm sure a lot of other places. But so opening it up for further discussion.
Yeah. Question for Colonel Prohorenko. Question for Colonel Prohorenko. Who runs the blood system in Ukraine? Is it under the Ministry of Defense? Is it the Army? Is it the Ministry of Health? How does the...
Please don't tap on microphones. We are in the headphones. Sorry. Apologize.
How do the blood products get from where they're collected in the civilian side to the soldier on the battlefield? And who runs it?
The Ministry of Defense, the Armed Forces, has a service that's responsible for donations. It is the so-called blood service. It's a separate structure that reports to the Armed Forces Command, and their units have a closed cycle from blood collection to processing into components, storage, and transportation. But we understand that this is not always sufficient. So therefore, the Ministry of Health, who is also working on the same issue and has their blood banks, is in close cooperation with the Defense Forces. So our hospital where I work, we can actually provide ourselves with all the necessary blood components. However, the combat units, mobile hospitals that are on the front line, as well as stabilization facilities, the situation is different there. They have direct cooperation with the Ministry of Health, and they use their stock, starting with the stage of collecting blood all the way to transporting it and distribution between various military units. There's a system of coordinators. Medical institutions have designated specialists who actually focus on blood service in particular. They arrange availability of donors for civilian institutions. At the same time, they oversee the blood deliveries to combat units. So there's close cooperation between military medics and civilian institutions. However, once again, I have to reiterate that within the military structure, we have our blood service that can provide the whole closed cycle.
Anyone else have any questions or comments?
It's not a question, it's just a thought. I wonder if the NATO militaries and the Ukrainian military have thought of military blood coming from NATO states going to the Ukrainian military on the front line. It's just an observation. I know that practically that's crazy, but this is a forum for blue sky thinking.
I've heard crazier things, Nick, so I think it's actually an interesting idea. Anyone want to comment? Okay. Okay, so, all right.
To add to crazy thinking, okay, so, and Andy and I were talking about this. The West, NATO, the United States, is concerned about having, you can't bring our boots on the ground, our soldiers in there. But our medics, doctors, nurses, medics, are all non-combatants. We all have a Geneva Convention card, all right? We are not soldiers. Is there a way that we would be available to help Ukraine?
I think you just volunteered for a commission. Any thought? Okay, sorry.
Thank you. So I was challenged during the coffee break to ask a relevant question. I know nothing about blood transfusion, but what I do know is that until 1 year ago, it was illegal for battlefield medics to perform blood transfusions on the battlefield. And the Cabinet of Ministers changed the rules to allow this. And my question to the Colonel is, after 1 year, have all the relevant battlefield medics received appropriate training and skills and experience to safely do blood transfusions in battlefield conditions?
It's hard to speak about all of the combat medics, whether they receive training, but as far as I know, there are efforts to do that. In particular, the volunteers that are interested in making sure that a wounded person receives whole blood or blood components as soon as possible, so type O blood in particular. So the volunteers focused on that and overseeing that. So indeed, such a decision to allow combat medics to perform blood transfusion was made, but there are some issues in combat areas. Why? Because it's a matter of transportation, storage, deliveries of blood to combat medics, and this required certain conditions to be met. But they are in an environment where everything is blowing up with the shooting, so there's a risk of this blood being rendered unsafe for transfusion. The stabilization facilities that are further from the front line, yes, this is more feasible, but the doctors are doing that, not the combat medics.
Just one question on a technical point for the Colonel. You said that sometimes the medical staff who are looking after patients will do direct transfusion from themselves. Is this they transfuse into a bag and then the bag is used for the patient? Or is this the historical three-way tap and a syringe that you take blood directly down the tube into the from the donor into the recipient?
That depends on the situation. If we have time to prepare a blood unit, then we would go for that. So we would do the packaging. But there are cases when at the same time the donor and the patient are on two tables next to each other. So direct transfusion. So it happens too.
Any other last questions, comments?
Yeah, thank you, Nick and Dr. Hudson. Both of your comments are very valid because when you're part of that fight, whether they are, obviously they're not going to send the troops, but we are using NATO guidelines, why not use NATO blood and NATO infrastructure to help the people who are fighting on behalf of you in some sense. We keep saying Ukraine in the forefront of Western democracy and civilization, and then we need to give them just more than weapons. We need to give more infrastructure, blood. I totally concur with you. So that may be the next step the Colonel and the authorities here should push for it.
And with that, so we're going to go ahead and round out this session right on time. We'll break for lunch. We want to thank all of our panelists. We really want to thank, I think, Dr. Capps. I hope he's still online. That presentation and your involvement was absolutely phenomenal. I think, and you're calling him from Paris, correct? I think so. Yeah. So thank you so much for taking the time to join us virtually. You have added immensely to our discussion, and I think given some really stimulating ideas for us to carry forward on. But I want to thank Dr. Kapp, all of our panelists, everybody in the audience for your participation. We will break for lunch now and come back at 2:30 promptly so that our esteemed colleague, Dr. Hudson Berry, and Haley Urin can further our discussions on wound infection care and prevention. But again, break for lunch, be back at 2:30. Thank you, everyone.